Good afternoon, and thank you for joining us for this very special lunchtime talk. My name is Alyssa Nedrow. I am the communications intern with Neglected Tropical Diseases Comms team. And today we have Phil Downs, who flew in just this morning from the States. So we're really excited that we were able to get you in here today and present to us. Today, Phil will be presenting his talk, which is titled, For Want of a Nail, Reflections on Reaching Hard-to-Reach Populations. The talk will ask what are some of the missing nails or solutions we need to think about so we can be confident in delivering our promise to control and eliminate neglected tropical diseases. Using examples of border issues and conflict areas, he will identify some of the areas where Sightsavers can lead in providing nails. So now I'll hand it over to you.
Good. Well, thank you everyone for being here. This is good? Yeah? It's really dangerous to have me presenting after coming off a red eye, because I have no idea what state of delirium I'm in right now, so who knows what's going to be coming out. But thank you. I know it's going to be a very busy week, and it's great that everyone's here in Haywards Heath. We have a lot of planning that's going on, so I think this is actually a great opportunity to be talking about this topic, about reaching hard-to-reach populations. And this picture right here is of Dr. Tawfik. He is the national trachoma coordinator in Yemen. And this is during the first mass drug administration for trachoma back in May of last year. And this was a huge battle that was won, and really exciting. And we'll talk more about this particular case. But I wanted to sort of frame this discussion about hard-to-reach populations. And when I talk about hard-to-reach populations, we're talking sort of geographically hard-to-reach. But to use a proverb, for want of a nail. And so maybe some of you have heard want of a nail. So I'm going to read for want of a nail, and I want you to think about, describe what you hear and see. There's actually a picture. Is there a problem, and why? Does the problem relate to the work you're currently doing, and if so, how? And then how have you overcome that problem as part of your work? Okay? Pretty simple. So here's the proverb. For want of a nail, the shoe was lost. For want of a shoe, the horse was lost. For want of a horse, the rider was lost. For want of a rider, the message was lost. For want of a message, the battle was lost. For want of a battle, the kingdom was lost. And all for the want of a horseshoe nail. Very simple. So describe what you see, the picture, or what you just heard. Very simple, right? What do you see here? Anyone? A horse.
In a dress.
A horse in a dress, okay. A horse that's sort of ready for battle in a way. A rider holding a horseshoe, but sort of saying, I can't get this on your foot because I don't have a nail. Is there a problem here? What's the problem? Anyway, this is easy stuff, right?
The lack of a very small, simple thing is having massive repercussions.
Yeah. Well, the nail is missing, so he can't get it. It's a very small thing. In sort of the grand scheme of things, there's a battle going on, and there's this kingdom up on the hill, and possibly they're going to lose this battle because, of this one nail. Right? Do we see the horse as a problem? No, the horse is not the problem. The horseshoe is not the problem. The nail is not the problem. This situation of not getting the horseshoe on the foot is the problem. Does this relate to anything that you're doing in your work?
Nah.
Nothing at all.
Yes.
Something that you're currently working on that comes to mind?
I'm not going to put you on the spot.
Yeah, no. Or anyone.
I think.
Yeah. Surely this comes up now and then.
Some difficulties like finding the right visa and getting the right visa for the cameraman to actually get into the country.
Right. Okay. So trying to get just the cameraman for comms purposes into Bangladesh, but can't get a visa. Very simple thing, but that just will throw off the entire trip, and we won't get the message across that we need in Bangladesh. That's a good example. Any others? It's a good one from comms. Wash? Nothing? Everything. There's a lot of pieces to the work we do in NTDs, and sometimes you think a very small thing you can ignore it, it's inconsequential, and then all of a sudden, you're already several months into the work and you realize, oh, we should have handled that ahead of time. For the people who have offered some suggestions, you have a solution for the visa that's going to be sorted out? It's working. It's often it's just being aware that there is that problem and that you need to be working on it. For some of the work that we're doing on NTDs right now, there are let's just say the nails will come in different shapes and sizes. There are a lot of different horseshoes and horses that we're dealing with. And I'm just going to throw out a few before I talk in particular about areas of conflict. Glue and fly traps. So part of the work we're doing in terms of monitoring impact with the work we do on elimination of river blindness depends on capturing black flies, right? So teams go out there, they collect the black flies, they look at whether there's transmission going on in black flies. Traps are used to collect black flies, but the glue that's applied to the traps have now been categorized as I think it's like a toxic chemical. I don't think it's the exact, it's harmful chemical that cannot now be imported into countries. So that's a huge issue now countries are dealing with. They have to collect a certain number of flies, and they can't even do that because they don't have the glue in the country. That jeopardizes all the work we're doing. So we're actually now looking at how we can do some research to see whether we can source things locally in countries so it doesn't have to be imported into the country. And there are homebrew recipes for glue. It's amazing what you can find online. Buffer and diagnostics, right? So this is another example. Not all of these are related to onco, but for onco elimination mapping, the new guidelines when they were looking at the protocol requires that the rapid diagnostic test, right, for seeing whether humans have infection, now have to be processed in the lab. And what they basically do is they elucidate a blood spot that was collected on a dry blood spot paper, filter paper, and then they do that in the lab. But you need this buffer. And there's only one place that makes the buffer. And no one thought about that when they came out with this protocol. So you now have this sort of initial guidelines that all these RDTs are going to have to be processed in the lab, but none of the labs have the buffer. So again, we're trying to work, Sightsavers is trying to work with the manufacturer, with ESPN, WHO, to see how we can get that stock in Africa, in countries, so to provide it to those labs. These little things that really throw everything off. Cash and workers. This is an example that just came up recently in Sudan, where everything is in place. And you can say you have the horses, you have the riders, everyone was ready to go into battle, and there's sort of crisis with the bank that no one can get actual local currency to pay the workers. Like literally, you go to a bank and you want to cash a check and they won't do it. That throws everything that we have. We're ready to do the MDA, but we can't even pay the workers because of the crisis with the bank. So again, we have teams that are looking at seeing how we can get a cashier's check, get to the central bank, maybe they will cash it, then we can, there's all these things that are going on right now that we're looking at solutions. Fuel for motorcycles, right? Often we have in our work plans how important supervision is, right, for the work we do. Doing an MDA to surgeries, you need supervisors going out there. We don't have the horse actually for them to ride on to get out and do the supervision. There's no motorcycle that was planned for, let alone fuel, the horse shoe, so to speak. And I would also argue that in a way, MDA and getting MDA into the communities that are hard to reach sort of fit this model. If we view trachoma elimination, global trachoma elimination as a public health problem, as sort of the kingdom, right? That is what we're trying to achieve, and that each battle, every country is going to have to fight this battle. Hard to reach populations are sort of that horse, that if we can't figure out a way of getting the MDA, which is a horseshoe, onto that horse, we will lose the battle in that country. And I'll explain again why that hard to reach populations are really, really critical to address now. When we look at sort of the global strategy of submission of dossiers. But I want to go back to the original picture of Dr. Tawfik in Yemen, right? So this was, and we could view also just in general, delivery of MDA to a hard-to-reach population as a battle to itself, right? In Yemen, getting just the MDA off the ground was incredible, and led to this amazing, media story. Against all odds, Yemen launches its first large-scale treatment campaign against trachoma, defying the odds. One doctor's story of preventing blindness in civil war. This is really a major battle that was won. And so it's really important to understand what happened for us to have achieved that victory. And so this is sort of a timeline, and I just wanted to sort of highlight 2 points where I think that were really significant. The first one was back in 2013, 2014, and Sightsavers work with the Global Trachoma Mapping Project that went in and was able to assess that there 2.5 million people were at risk. This actually showed that we actually had a battle to fight, that there were populations in these areas that we needed to bring services to, Mass Drug Administration. They needed to be targeted. So that sort of set that we had a battle to fight. So then in 2015, unfortunately, a lot of the activities had to be suspended because the conflict was ramping up. And 2016, much of the country was torn apart by the conflict. And by the time we got to 2017, the UN says that the war is part of the worst humanitarian crisis since World War II in Yemen, which is shocking. But at the same time, that year, Zithromax was still shipped to Yemen in preparation for Mass Drug Administration. How did that happen, right? How is it that they were still able to send drugs even though that this was sort of the worst humanitarian crisis since World War II? And that really goes back to a meeting that was held in Geneva in 2017. So it was Sightsavers, CBM, Fred Hollows Foundation, and ITI came together, and this was uniting, and WHO sort of brought these partners together, but we all agreed to co-fund and support this MDA. There's great risk in supporting MDA in a conflict area, but getting this sort of partnership together and people willing to support something that was risky, but doing it together, if that didn't happen, there would never have been an MDA last year. This would never have happened. So this was an important solution, a nail to a problem that we need to sort of look at. And we've sort of used the lessons learned from Yemen and carried that over to other situations as well. So we have, for example, in South Sudan, Onco Mass Drug Administration. We've been looking at, a partnership with NFund. So we've received funding from NFund. We've also last year co-funded some of the MDAs for Onco. If that hadn't happened, there would have been no Onco MDA in South Sudan. And so we're trying to build on that momentum going forward, which is exciting. In Egypt, HSBC funding is going to support trichiasis surgeries. Everyone thinks, Egypt, they must have all the resources. They don't. And this allows us to at least initiate some initial surgeries in Egypt and get the momentum, sort of the ball rolling there, to build upon really a fragile program at this point. We see this in Sudan as well with supporting trachoma, again, Mass Drug Administration, looking at creative ways of partnerships, bringing in other funding to really try to get MDA into some really hard-to-reach areas. We see that with the onco-elimination mapping in Mozambique. There's a huge humanitarian crisis, obviously, going on in Mozambique right now, but Sightsavers is looking at ways of how we can support mapping still, not getting in the way of the humanitarian efforts and relief, but for many people in Mozambique, they want to get back to normal, and so part of that is offering services. And mapping is part of it. Identifying where the battles are so we can ensure that people get treated. And even looking at, in Cameroon, in the western part of Cameroon, looking at nomadic populations. These are populations that typically are not, it's been more difficult to reach those populations with Mass Drug Administration. So SPIDER's looking at ways of improving how we deliver services to nomadic populations in Cameroon. So I think these were some of these lessons learned and sort of seeing that it's possible in a place like Yemen, in a war-torn area, that we can also apply some of those lessons learned in other areas as well. And this is why I wanted to sort of highlight why focusing on hard-to-reach populations is so critical. So we have this sort of, it's not so much a continuum. Not all diseases are created the same, right? So we have control programs in many countries for schistosomiasis and soil-transmitted helminths. They will only control the disease, which means that they will achieve a certain level of prevalence that's locally acceptable, right? When we look at elimination, there's two categories. There's elimination as a public health problem, which trachoma and lymphatic filariasis fit under, and those are globally set targets by WHO, and so once those are achieved, it's both for infection and the disease. Then there's elimination of transmission, which is for river blindness, onchocerciasis. In this definition, you are achieving zero transmission in a geographical area. So there's a slight difference, but it's really important to note that there is this difference. And then you have eradication, which right now guinea worm and polio are two diseases that are being targeted for eradication, although some will argue now that guinea worm cannot be eradicated because of the dog problem. There are certain countries where they've identified dogs as being a major reservoir. But this is where it's important because in general, right, when we look at our strategy for eliminating diseases, we go in, we map, we identify where the battles need to be fought. We start Mass Drug Administration, we look at WASH, we look at vector management, behavior change activities, we look at patient care and providing services to people with the disease itself. After a certain number of years of Mass Drug Administration, we stop, we do an impact assessment survey. Depending on those results, we determine whether we have to continue to treat or intensify activities. There's a post-treatment surveillance period where we go back and look at prevalence depending on the disease, every 6 months, sometimes every year. And then you submit your dossier, but this is at country level. A country cannot submit their dossier if they ignore the hard-to-reach areas, meaning they have to grapple with this issue now. So in parts of Nigeria, in the north, where there's a lot of instability, we need to grapple with those areas. If those places are endemic for diseases, we need to find out model solutions for getting drugs and other services to those areas. That's just one example. There's a lot of different areas that we're trying to figure out how best to provide those services because the country will not be able to submit their dossier until those areas are addressed. And that's why it's really critical now this week as we're planning with the Accelerate project and the new Ascend project as well, that we start looking specifically what are the difficult to reach populations, right? And I would say that this is part of who we are at Sightsavers. If we look at our strategic document from the NTD department, Now is the Time to Say Goodbye to Neglected Tropical Diseases, when we look at supporting NTDs and in communities, looking at MDA, WASH, surgery, case management, each of those groups needs strong leadership to ensure we are delivering services to neglected people, right? These are not neglected diseases, these are neglected populations. These are the hard to reach populations. So this is part of who we are. This is written in our strategic document. And we, at Sightsavers, we've also been able to influence at a very high level through various articles. Simon and Julie Jacobson wrote an article, Neglected Tropical Diseases, Neglected Communities, and Conflict. How do we leave no one behind? And this article really sort of lays out the need for adaptive programming, innovations, flexible funding, opportunistic partnerships, and empowered communities, which I really think the Yemen model captured this very, very well. It also carries our thoughts in an article on cross-border issues, an important component of onchocerciasis elimination. And in this article, we say, you know, typically when people think of cross-border issues, they think about between two countries. But this article also defines other cross-border issues, and that can be internal. It could be between administrative levels. It can be between different ethnic groups based on linguistics, because physical barriers within a country. There are a lot of different borders that separate people and make some accessible and some less accessible. And it's really important to define each of those groups in a country. And it also sort of really highlighted the need to involve, NOEC stands for National Onchocerciasis Elimination Committees. So within each country, there is a mechanism for review and looking at these populations, and they need to be involved in it. It's not just us, it's not external support, it's also within the countries that they have a role to play and communicating that at lower levels. So that really highlighted that. And then there's as part of the NNN, and does anyone know what the NNN stands for? Leah. NTD-NGO network. Yes, the NTD-NGDO network. So Sightsavers is part of this organization, and there is a working group, Conflict and Humanitarian Emergencies. Bex, myself, Louise, Heather are on that group. I don't know if there are others on it, but I think that's it from the NTD department. But there are 3 task teams that look at mapping, sharing best practices and solutions, and advocacy. And even though they're focused on conflict areas, a lot of the solutions they are coming up with and we are contributing to also apply to other areas, even though it's not, a conflict area, to other communities and populations that are hard to reach. So again, these are just sort of examples of where Sightsavers is contributing right now. And we have a huge reach, obviously. When you start looking at the new projects that are coming on, we cover a huge geographic area. And when each one of these countries, it is important for us to have this conversation with the national programs to define who are the hard-to-reach populations and start forging some of those nails, the solutions of getting the horseshoe on to the feet of the horses. If we don't, we're going to lose the battles and then the kingdom, and that's what we're trying to avoid. I'm going to end right there, short and sweet. I know there's some other meetings, but if people have some thoughts or questions or about this topic throughout the week, I know it's going to be coming up as we're planning.
Are there any questions online as well, or in the room?
What's the nail you're most concerned about?
So if the nail is a solution, right? First of all, I just want to say, and it's really important when you hear sometimes programs talking about like nomadic populations. They'll say, oh, they're so they're a problem. That population is a problem, and that always concerns me. It's not the population that's the problem, right? Because they've adopted a nomadic lifestyle, that is not the issue. The issue is we need to come up with a way of providing services to that lifestyle. So I get concerned, working in countries where they identified nomadic populations, fishing communities as problem. Why can't they just settle? And that's how we're going to figure things out. That is not how we're going to figure things out. We need to come up with better solutions for reaching fishing communities. That has come up several times when we look at transmission and why certain areas continue to have onchocerciasis and schistosomiasis. It's because we haven't figured that population out, and because it's so inconvenient, and people say, oh, it's just too many resources, it's just too difficult. You're going to have to face that at some point. If you want to submit a dossier, the country needs to start tackling those issues. So I would say nomadic populations, which typically people think of like cattle herders, but it's also the fishing communities as well that are really hard to reach. That's a big concern.
I think we saw that in in Zimbabwe last year. We went to do some filming, and we were up in Bire, and there were two quite distinct communities there. There were the sort of indigenous population who were called the Doma, and everybody else we met was kind of from the other community, who were largely people who'd come over from Zambia, and they were quite engaged with health programs and that sort of thing generally. Doma, who were the original sort of population, weren't at all, and historically had never been. And we heard exactly that quite a lot. They're very difficult to get to engage in health programs.
Right.
They tend to, they see a 4x4 coming and they tend to run away. Those sort of issues. But figuring that out.
Well, figuring that out, and I think we have lessons that we can learn from other programs. So the guinea worm eradication program, I know their work in Mali, for example, working with the Tuareg, there was very contentious between the government-owned national program and the Tuareg groups. They didn't have a single supervisor or anyone at a high level that were from the Tuareg tribes. And it was only until they sort of reached out and said, okay, we need to have more people from the communities actively involved in planning and the decision-making process, that they started to make headway in reaching communities. So I think that is something that we need to look at. Yes?
When I speak to some individual donors, they're absolutely amazed that we're able to work in Yemen with them. I just wanted two questions. Firstly, so I can really relate to them, what is it about that partnership and the way it operates that's made that possible? And the second question would be, for those people on the ground who are trying to make it happen, what is it, what's the mindset that enables them to progress it?
Yeah. I would say that in the case of Yemen, a lot of credit has to go to Dr. Tawfik. I think his leadership style and sort of can-do attitude was absolutely essential to give the confidence in the partners to say, let's work together, let's put in the funds and do this. He was very successful also looking at, and this is something that was highlighted in the article, was empowering communities. I think we all know that the work we do, it's not Sightsavers going out into the field and delivering the drugs. It's the government working with communities that make MDA and all the services we provide possible. And so Dr. Tawfik really sort of emphasized that community mobilization and empowerment. And for communities that have been devastated by war, again, as I said, with like Mozambique, people want to get back to normal. And one of those ways of trying to get back to normal is participating in services that help your community. And so I think that very quickly they gained trust, working with the right stakeholders, imams and other religious leaders to gain the confidence. They hired an army of women community drug distributors who went out. And I think that was a really good example of you need to have a good general, whoever that is, to sort of lead the troops, and he was definitely a good example of that.
questions online?
Yeah, there is a question online.
Just remember to repeat it.
Sorry.
Yeah, so it's a bit of a statement to start with. So there is resistance in targeting hard-to-reach populations owing to difficulties and funding. Do we have enough advocacy tools? How else can we get funders and other stakeholders interested?
Do you want me to repeat that again? So what sort of advocacy tools do we have available to us? Do we need new ones to get donors and other people interested in investing in the hard-to-reach areas? That sort of... Yeah. Comms team, you may have some better ideas than I do, actually, in terms of advocacy and some of the things like you might be thinking about. But I do think that this is something that we do need to have more advocacy tools on, and bring attention to this and more stories about. We talk about the conflict areas, but as I said, I mean that's just one population that's hard to reach. The nomadic populations, the fishing communities, areas that are cut off because of linguistical issues. Those are also part of this, and that we also need to sort of define and remind people about.
There's a suggestion for an answer online as well from Rogers, who said it's almost certain that coverage in these groups are low. To better equip for advocacy, we may need to establish infection levels in these communities and show this can be overturned through hard work.
Right. So that's a really good point from Rogers. And Rogers is leading some of the research looking at nomadic populations in Cameroon. And that's always sort of one of the questions that comes up is, well, do we really need to worry about these populations? Maybe they don't have any infection anyway, so it's maybe not a battle we need to have to fight. But the point is that we need, so he's right, we do need to go in there. We need to demonstrate that there is in fact infection in these populations, so they become a priority. I think that is a very good strategy. And so where mapping typically happens is sort of a cross-sectional study. It's for the entire population. We may need to look at more specific mapping techniques targeting hard-to-reach areas.
Sure. Thank you. Do we know what's going to happen next with Yemen? Have we got a plan?
Oh, I was hoping no one would ask that question. No, I think there's... Yes, there is renewed interest to continue. They were successful, obviously, in the first MDA, but that is just the first battle. They have many more battles to fight, and that will require additional resources. We've shown they have good leadership, that they can mobilize people and provide services to people. It's that continuity that we're continuing to fight for. But there is interest, and hopefully another MDA will be conducted this year. Yep.
I was going to say for Yemen, they are preparing to do surveys now in the areas that had the MDA. They're very clearly ready to start that.
Yeah. I'll just repeat that. Yeah. So in some of the areas that haven't been mapped yet. So as I pointed out, that was sort of the starting off point to get this initial MDA off the ground, is identifying the populations to treat. So this next round of looking at other areas that still need to be mapped to determine which populations need to be treated. So, yep. Yen.
So I was on the other side of the Yemen story because I was in Lisbon at the time. But just to stress that I think one of the biggest lessons I took from that whole GTNP, shall we go into Yemen, how do you get money into Yemen, all of those questions, was that I think it's an excellent example of adaptive and flexible.
Yeah.
Not just by DFID, but by Sightsavers, everyone involved. WHO got involved, so bringing the partnership issue, but it just really highlights you have to be prepared to be flexible.
Yeah. So, just to repeat what you said, it's just the need for adaptive financing and partnerships for conflict areas. It's not one organization that's going to be able to tackle it. It really is reaching out to a number of different partners, and maybe partners that we haven't identified yet in some instances. But the need for flexibility with the funding and understanding there is risk, and that is acceptable. And because, as I said, if we don't tackle it, we're not going to be able to reach the kingdom, which is elimination for these diseases. So.
Sorry, can I throw another nail there?
Please.
Polio.
Another nail.
Polio eradication.
Oh, yeah.
That potentially down the line, we've got a big issue that in quite a lot of countries, WHO staff working on disease surveillance, for example, are actually being funded by the polio program.
Mm-hmm.
And as we get closer to eradication and as funding goes down with polio eradication, you might well see staff in country, WHO, and therefore the engagement with country government, national government, on disease surveillance forward. So I think it could potentially be an issue for us.
Yeah, that doesn't sound like a nail. That sounds like more problems. No, but that's a point well taken. That the infrastructures that have been supported by WHO for polio eradication, that as that program is wrapping up in a number of countries, that infrastructure is disappearing, and it is vital for the integrated disease surveillance and response teams in many of the countries, and that is a critical component for the work that we're doing, that we want to make sure that infrastructure remains and continues, not only for the diseases we work on, but other diseases as well.
We have one more question online.
Sure.
From Serge, who says, is there not a contradiction between the idea of a resident that we have and the notion of nomadism, so travelling people? So how should we reach those?
Say that question again, sorry.
Is there a contradiction between the idea of a resident,
a resident population,
yeah, and the idea of nomadism?
Well, I'm not sure I totally understand the point, but I think they are two different, populations that will require different strategies. So I don't know if you have a better sense of the contradiction, but
the question of how we're counting them, is that what it's about? Like, are people counted as resident population of a country, but nomads by their nature are moving around all the time? How do you capture the nomads in are you capturing in the population of the country as opposed to the country?
Yeah, no, that could be it. And I mean, two points. I mean, I think it goes to Roger's point about identifying where the sources of infections are, whether migratory populations are a reservoir for infection, or transmitting it to other populations, but also how do we capture that in terms of our calculations and targeting, and it is tricky. We'll see sometimes populations where they've reached 120% coverage, and everyone sort of laughs, and they're like, your denominator is wrong. But then you sometimes go in and ask the question of like, come on, how did you do 120%? And they're like, well, actually, there was this whole migratory group that came into this area, and we ended up having to treat them. So that wasn't part of our initial denominator. So that's good. We want these populations to be treated, especially if they're coming into an area where there is transmission happening. So, but yeah, it is. Maybe was the point.
Yeah, and Mike was right. Serge just
okay.
That was
that was the point. Okay, thanks. Good. Yeah?
Great.
Yeah.
Good? Great.
Alrighty.
Thank you, everyone.
Thank you, Phil.
Right. So thank you guys all so much for coming in on your lunch break, and a big thank you again to Phil for presenting today and sharing such an important aspect of the work Sightsavers does. So yeah, I will circulate this around once we have it all edited together. And if you have any questions for Phil, feel free to ask him while he's here this week. All right. Thank you.